As we started the beginning of the day, I asked a question, who had ever met another person with autoimmune hepatitis? I'm going to rephrase that question. How many of you have ever seen a real-life pathologist? Oh, more than I thought. Wow, okay. Well, for those that haven't, we have the amazing ability to have Dr. Oscar Cummings. He's one of our IU hepatologists here. He's a Lawrence M. Roth professor in pathology. He has special interest and focus in liver and gastrointestinal diseases, including transplant pathology. He remains a real integral piece to the evaluation and treatment of liver disease here at Indiana University. So, Dr. Cummings, thank you so much for coming.
Thank you very much for inviting me and that kind introduction. I'm sure everybody's tired, so I'll try not to take up too much time here. Basically, I figured that most people didn't know a lot about pathology, so I thought I would just tell you a little bit about what we do and then hopefully show how we integrate into the team approach of taking care of patients with autoimmune hepatitis. So I don't know if anybody remembers back to sophomore biology, but I just thought I'd briefly go over it. The first microscope was invented by Leeuwenhoek back in the 1600s, and he ground his own lens. That's the lens there, and it had a magnification factor of about 270x, and he would impale the specimen on there and manipulate it with these screws, and he'd look through the back of it and hold it up to the light, and that's how he examined things. And he published a number of microscopic observations. And he did look at cells, and if you remember, all cells come from other cells. That was first articulated in 1855 by Virchow, who was one of the first pathologists in the world. And this is a picture of cells in culture, and I'm sure everybody remembers mammalian cells have a nucleus, they have a cell membrane around here, and then cytoplasm. And I'm going to show you pictures of cells, so I just wanted to remind everybody of that. And cells are the fundamental structure of human life. A tissue is an assemblage of cells from the same origin, and together they carry out a specific function. And an organ like the liver is actually a functional group of different tissues. If you study tissues, you're studying histology, and the study of abnormal tissues is surgical pathology or histopathology, and that's what autoimmune hepatitis is, and a pathologist is someone who looks at abnormal tissues. So I'm sure most of you probably had liver biopsies if you had autoimmune hepatitis, and I just basically show what happens to that liver biopsy after the radiologist takes it out. They put it in a formalin-filled vial. It has your name and all your information on there, and they give us a sheet that hopefully has some history on it, but sometimes it doesn't. And we put a number on there so we can find it again, and that same number is on the jar. And then we put it in cassettes, and these cassettes have that same number on it, and that's how we track your specimen through our system all the way. So with a simple specimen like a liver biopsy, they just take it out of the jar with the formalin fixation in it, and they put it in the cassette. And then the cassette is loaded onto these machines. I won't go through all the details here, but there's a vat here, and this is just a different manufacturer, but it's the same machine. And there's a vat in here as well, and we put all the cassettes that we accumulate over the day in this machine. We process about 2,000 blocks, those cassettes, a day. And then we use a lot of chemicals, and the machine automatically recycles the chemicals. So the first few vats of chemicals are formalin to make sure the tissue is fixed. And then we use grated alcohols that takes the water out of the tissue. And then the last one is a xylene step that takes all the fat out of it. And then we replace the water and the fat with paraffin or wax. And there's a bunch of wax in here. And this is all automated in this computerized machine. So this takes overnight for processing, and that's why you don't get the results back instantly. And what comes out at the end, we open the cassette up, and there's a little piece of liver that's now feels like wax because the water and the lipid has been replaced by the wax. We put it in a mold, and then we put the cassette back on top of the mold, and when the wax hardens, the tissue is fixed to the bottom of the cassette that still has your number, so we know that that liver biopsy specimen belongs to you. Then we have technicians that cut this paraffin block. This is a microtome. The block fits in a special slot, and then there's a razor blade here, and we cut this wax block at 5 microns thick. It's less than the width of a human hair. And then these ribbons of paraffin that have the liver tissue in it are floated in this water bath. And then we take glass slides, and it has a label with your number on it, the same number that tracks your specimen, and then we pick those ribbons up. And so now the tissue is stuck to the glass slide. And then we run it through this automated processor here that puts different dyes on it. So we use a red dye and a blue dye to help us see the tissue underneath the microscope. The red dye is called eosin, and the blue dye is called hematoxylin, and this machine automatically stains the slide. And then we have an automatic cover slipper that puts a little thin piece of glass on top of the slide, and that's what we look at under the microscope. And here's a picture of my microscope several hundred years after Leeuwenhoek's original scope. So I have a binocular scope. I don't have to hold it up to the light. It has a built-in light source. And the lenses here are about 10x magnification, and I have multiple different lenses on the bottom that I can put in and out. So I have a total magnification between 20x and 400x. But most of the pictures I'll show you are taken at about 200x, about the same magnification that Leeuwenhoek had back in the 1600s. So here's what the slides look like, and I look at them underneath the scope, and this is what I do all day. So, and I drink my coffee, and I have my books. So here's what the liver looks like under the microscope. Has anybody ever seen anything like this before? Or? So if you remember, the liver weighs about a kilogram, and it's stuck up under your rib cage on the right side of your abdomen. And the portal vein and the hepatic artery and the bile duct go in at the hilum, and then they kind of branch out like the branches of a tree into the liver. And when they get smaller, you can see what they look like under the microscope. And this is a branch of that tree here that's called the portal tract. And here's a branch of the hepatic vein. Here's a branch of the hepatic artery, and here's a branch of the bile duct. And you can see they're in this kind of triangulated structure here. And this is all a tissue. It's organized cells. And then these are the liver cells themselves, the hepatocytes. And then this is the central vein here. So blood comes in the portal vein and the hepatic artery, and it percolates among the hepatocytes and gets collected up in the vein and then drains back into the heart. Remember all this from biology, sure. And so you can see what the hepatocytes look like with our dyes. The nucleus of the hepatocyte is stained blue, and the cytoplasm is stained red or reddish. The only thing that's pure red are the red blood cells that you can see there. And there's sinuses here. You can't really see them, but they're little spaces in between the hepatocytes, and that blood percolates through there. Maybe there's a sinus there that you can see. There's some support cells. These are called Kupffer cells and endothelial cells. They just kind of make up the support structure of the liver, but they don't do the work. The hepatocyte is the cell that does all the work, and it does an amazing amount of things. It synthesizes thousands of proteins, and it detoxifies lots of chemicals. So if you injure or lose your hepatocytes, those functions don't happen, and you run into problems. And so that's what it looks like microscopically. The enzymes, the AST and the ALT, are the liver function tests that you often get drawn your blood for. Those enzymes reside in the cytoplasm of these hepatocytes, and if you injure them, they leak out into the sinuses, and those levels go up in your blood. So that's sort of how it works, basic pathophysiology. And we do some special stains as well. This is a trichrome stain that helps us see how much fibrosis there is. And so again, this is hopefully normal liver. And that portal tract we talked about has fibrous connective tissue in it. That's normal. And there's a little bit around the central vein, but there's nothing in the lobule here where the hepatocytes are. So this is kind of what it should look like normally, and I'll show this a little bit further on. So I'm going to just kind of briefly talk about autoimmune hepatitis as a pathologist sees it. Most of the time it's a chronic hepatitis, and our job is to do staging and grading. Occasionally it's an acute hepatitis or a fulminant hepatitis, and I'll briefly mention that, briefly mention the overlap syndromes and a few other things. I'm not going to talk about transplantation. The histopathology of autoimmune hepatitis basically looks the same in the transplanted liver, so not particularly different. So did a nice job. So why would you get a liver biopsy? So there's lots of diseases, of course, and we're just interested in autoimmune hepatitis. And a liver biopsy is kind of good for 4 different things. Diagnosis isn't always one of the things. It's more important usually for staging, prognosis, or management. Although you can see that in autoimmune hepatitis, the liver biopsy does have a role in diagnosis, but it's primarily for staging. How much advanced is it? How much disease is it? And then that influences management. So that's why they do liver biopsies. And from the diagnostic point of view, there's a diagnostic algorithm for making the diagnosis of autoimmune hepatitis, and I'm sure someone else has gone over it. I've just excerpted the parts that have to do with the liver biopsy. So in chronic autoimmune hepatitis, if you have an interface hepatitis, I'll show you what that looks like. You get 3 points. If they're plasma cells, you get 1 point. And rosettes are injury to the hepatocytes themselves. You get a point for that. And you add that up with other factors. Do you have elevated transaminases? Do you have autoimmune antibodies? And together that makes a diagnosis of autoimmune hepatitis. If you don't have any inflammation in your liver, you lose 5 points. If you have damage to the bile ducts and not the hepatocytes, you lose points for that. It's probably some other disease. And I'll show you a case that doesn't look anything like autoimmune hepatitis, but might be confused for that. And so here's our liver again, stained with our red and blue dyes. The portal tracts now have this dark color because they're filled with inflammatory cells that weren't there in the normal stage. So here's a portal tract, here's our hepatocytes, here's a central vein, hepatocytes, portal tract, hepatocytes, central vein, hepatocytes. This pattern normally repeats in the liver. And you can see the problem here is that the portal tracts are expanded, and now instead of those nice triangular and oval shapes, some of them look like maple leaves. And what's happening is these inflammatory cells are destroying the hepatocytes. And this is what's called interface hepatitis. You get 3 points for that. And as these hepatocytes get destroyed, your transaminases go up. And here you can see a branch of the bile duct. Here's our branch of the hepatic artery. So this inflammation is here predominantly in the portal tract, and it branches out to destroy the hepatocytes. Here's a bit of a rosette here, so you get another point for that. And there are tons of plasma cells in here. This is basic histology, but a plasma cell looks like this. The cell is there, and you can see the cytoplasm. The nucleus is off to the edge. It's not in the center like in the other pictures I showed. The cytoplasm has kind of a purple hue, and there's this little Hoff here, or clearer space in the cytoplasm, that is called a Golgi apparatus. And so all these cells in here are plasma cells. There are other cells in here like lymphocytes. It's a mixture of inflammatory cells, and these are the cells that damage the liver. So in this particular case, you'd get all the points, interface hepatitis, plasma cells, and rosettes. And like I said, the main purpose of the pathologist is to grade and stage. And so the grading is how much injury do you have, or you have a flare or anything like that. That's the reflection of the injury. And here are some of the basic criteria. So you get changes at the interface, and the more damage at the interface that you get, the worse it is. And you can also get changes out in the lobule between the portal tracts and the hepatocytes. And again, if you kill off a whole lot of hepatocytes, it's worse than if you just injure a few. And so this is this is basically the approach I take for grading the inflammation. You can also do staging, which is how much fibrosis is there. There's dozens of different published grading and staging systems. These are 2 commonly used ones. I personally use the Medivir system, and I use these words to evaluate the inflammation. My colleagues tend to use this Batts-Ludwig system. Ken Batts and Jürgen Ludwig were pathologists at the Mayo Clinic. Dr. Lugwood retired, but Ken Batts is still in private practice in Minneapolis. But the fibrosis is a little bit different between these two groups. The staging, or the grading is the same, but the staging is a little bit different. And the only important thing is that whatever your hepatologist is used to using and the pathologist that's looking at the slide, it's just important that they communicate. It's not important which system they use. And just as a cartoon to show you what happens, here's our normal portal tract. Here's a triangle in our lobule with the hepatocytes and a cartoon of the central vein. So here's our normal state. But in autoimmune hepatitis, you have all this inflammation and the portal tracts are bigger. And as that inflammation destroys some of the hepatocytes at the interface, sometimes it heals up with a scar. And that's what this light white line is supposed to represent. So there's a little bit of scarring there and there. So this would sort of be stage 1 fibrosis. But as the inflammation and damage progresses, you get more and more scarring, and the scarring gets bigger. And every now and then it'll connect up with another structure. So here's a scar that bridges across the portal tract all the way to the central vein. So now you're starting to get a loss of the architecture of the liver. And as it progresses all the way to a cirrhosis, what happens is the portal tracts and the central veins get incorporated into a fibrous scar, and there's no longer a central vein inside the hepatocyte lobule. And now the blood flow doesn't work like I showed you in the normal liver anymore, and this leads to some of the vascular problems that you get in cirrhosis. Here's a gross picture of a cirrhotic liver where you can see these small round nodules that are all under 3 millimeters in size. So this is a micronodular cirrhosis, and this is the most common pattern that you see in autoimmune hepatitis. And this is what it looks like under the microscope. And you can see where those portal tracts were, and the central veins are now incorporated into these fibrous bands as well. The white holes are fat. It's Indiana. But there's no central vein. And you can see how these nodules are all through the liver. And this is what cirrhosis looks like under the microscope and sort of how it comes about. Just briefly touch on a few other things. The idea that autoimmune hepatitis could be acute or fulminant is a relatively recent concept. Some people may disagree with that, but this is one of the better studies, I think, since we wrote it. Where we kind of reported on multiple cases of acute and fulminant autoimmune hepatitis, and I'll just show you some pictures of that real quick. Here's a case I just saw recently. Here's where the portal tract is, and you can see the hepatocytes are here. There's some hepatocytes here, some hepatocytes here, central vein, and you see this big swatch of where there's no hepatocytes anymore. It looks a little bit like that cirrhosis that we saw. And up close, you can see there's a lot of interface hepatitis. There are some rosettes in here. And these are all plasma cells. So this is a bona fide autoimmune hepatitis, at least from the histologic point of view. Hopefully the clinical information would correlate with that. And one might worry that this could be a cirrhosis if you looked at just the H&E, the stains that we showed you. But here's that trichrome stain, and all you can see is the blue, and it's in the portal tract and nowhere else. So this is an acute hepatitis that has bridging necrosis. It's not fibrosis, not cirrhosis yet, it's just necrosis. The necrosis can heal completely without fibrosis, or it may scar down and give you a cirrhosis, but it's not at that stage yet. So here's a fracture of the bile duct, here's the portal vein, here's the hepatic artery branch, and you see the blue is just confined to that. So this is an acute hepatitis that's due to autoimmune hepatitis, yeah. And hopefully therapy would fix this up. I got a case 15 years ago that it was a younger person, I can't remember if it was a man or a woman, but it had been called cirrhosis, and they had a biopsy a year later that was completely normal, and they were at a loss to explain that. And they didn't have cirrhosis. What they had was an acute hepatitis like this that just had bridging necrosis. The therapy had worked, and it had all healed up, and then they had a normal liver at follow-up. So kind of important to make that distinction. And here's a case again that looks a little bit like cirrhosis. You have these kind of nodular areas and then this connective tissue. excuse me. But at a little higher power, you can see there's no hepatocytes. So here's our portal tract. Here's our bile duct, our hepatic artery branch, our vein. And here's our central vein. And this is just the scaffolding of the liver, the connective tissue, if you will. There's not a single hepatocyte on the screen. And so this is fulminant hepatitis, where these patients are acutely ill and we would need to do a transplant for this or they're unlikely to survive. And there are plasma cells in here. And these little ductules, should the patient, you know, if you could do like dialysis for the liver, these would regenerate into new liver cells, but without that actually existing, you die without a transplant. So this is a fulminant autoimmune hepatitis. And let's see, just to touch on a few other concepts, overlap syndromes. This isn't so much as important for patients with autoimmune hepatitis because it doesn't really impact on the therapy. But if you come it from the other way where the patient's thought to have primary biliary cirrhosis and you see inflammatory changes, those people probably ought to be treated with autoimmune markers. And what happens in an overlap syndrome is, there's clinical and histologic features of autoimmune hepatitis, but features of some other diseases like primary biliary cirrhosis or primary sclerosing cholangitis. And I'll just show you one example here. This is from a recent article by AIHA looking at these phenomenon. And the patients have autoimmune primary biliary cirrhosis, for instance, have the clinical features of autoimmune hepatitis, but they also have a positive antimitochondrial antibody, which is a feature of primary biliary cirrhosis. And then they'll find overlapping features on the biopsy. And there's not much to do about that. There's no treatment for primary biliary cirrhosis. They might just add in agents to lower the bilirubin levels, but it doesn't affect other therapy. And likewise, sclerosing cholangitis, patients have all the features of autoimmune hepatitis, but they also have changes on their ERCP that show duct strictures, which are characteristic of primary sclerosing cholangitis, but not autoimmune hepatitis. And again, it's difficult to manage that. It doesn't require any more medication, and it may impact your long-term outcome, so it's important to notice it. But like I said, the criteria are not well established, and that's difficult for the pathologist to appreciate that. I went to a symposium for Dr. Ludwig at the Mayo Clinic when he retired, and one of the speakers was going to talk about this, and he said, "Oh goody, I've never seen a case." So it's somewhat controversial. So here's a case of autoimmune hepatitis where you can see a lot of the plasma cells. Here's a portal tract here. Here's an interlobular bile duct. And you can see that some of the inflammatory cells are damaging the epithelium of the bile duct. And then there's this poorly formed granuloma here. So this has features that overlap autoimmune hepatitis and primary biliary cirrhosis. So this is a relatively characteristic finding in primary biliary cirrhosis. So this is a patient that potentially has an overlap syndrome. But this is a clinical pathologic correlation, so we'd have to talk with the hepatologist and make sure that fit together with the clinical findings. And let's see, I just mentioned drug-induced autoimmune hepatitis. This is my generic picture of chronic hepatitis. But there are a lot of drugs that can produce autoimmune hepatitis-like features. Histologically, under the microscope, looks identical to autoimmune hepatitis. There's no way for a pathologist to tell a drug-induced autoimmune hepatitis from a de novo autoimmune hepatitis. And there's a number of drugs that are associated with this. It's just a small list. There are many other drugs and idiosyncratic drugs. But for instance, these drugs give you the exact histology of autoimmune hepatitis, and you get serum elevations of the anti-nuclear and anti-smooth muscle antibodies. Here are some drugs that give you the same histology and elevated liver-kidney microsomal antibodies, and there are a few that have no serum markers. The importance of figuring this out is that it doesn't need any more therapy other than discontinuation of the drugs. So it's important to make that distinction from regular autoimmune hepatitis. And again, this is a clinical pathologic correlation between the hepatologist and the pathologist to arrive at the right answer. And then one other thing I wanted to mention was that sometimes I get biopsies that said rule out autoimmune hepatitis, and I look at the biopsy and there's just fatty liver disease there. And we did a study where we looked at almost 1,000 patients with non-alcoholic fatty liver disease, and about 20% of those patients had elevated autoantibodies, elevated anti-nuclear antibody for the most part. And we looked at all the different other parameters, but in the end we found out that the autoantibodies can be positive in this non-alcoholic fatty liver disease, but in the absence of histology that looks like autoimmune hepatitis, these patients behave just like fatty liver disease, and they don't have autoimmune hepatitis for all intents and purposes. And this is what that looks like. You can see a portal tract here. The central vein is in here somewhere. And there's fat, ballooning. There's Mallory-Denk bodies in here. So this is fatty liver disease. There's nothing wrong with the portal tracts. They don't have autoimmune hepatitis. And that's how the pathologist can help out in this situation. So this would be a patient that would have the -3 because they had some other disease on their biopsy. So I just wanted to show you some of the things that go on behind the scenes in processing your tissue after you had a liver biopsy, and hopefully I showed you some of the ways a pathologist can interact in your care, and hopefully for the best. And thank you very much.